Good morning, everyone. My name is Doris Rodriguez, and we'll get started in just a few minutes while we give people a moment to get situated. So if you need to get anything, please do so now. We'll get started in a couple of minutes. I also want to make sure to announce that this presentation is available with automatic closed captioning. Additionally, we are providing simultaneous interpretation in Spanish this morning, for which I will now provide instructions for our Spanish Zoom attendees to join. Hoy siempre brindamos servicios de interpretación simultánea para nuestros eventos, igual en persona o en Zoom. Favor de hacer clic en el globo al fondo de su pantalla donde dice interpretación, luego haga clic en el idioma que desea escuchar, en este caso español. Si quiere escuchar solo al intérprete, puede también hacer clic en Mute Original Audio, que silenciará el audio original. Muchísimas gracias. Y de nuevo, bienvenido a Sinergia. Estamos agradecidos que esté con nosotros aquí. Before we begin, I want to let you know that we are broadcasting today's event live on Facebook. So I want to give a warm welcome to those that are joining us there. Quick question. Sorry, I can hear the interpreter. I don't know why.
I can start
No,
whenever
yes,
you're ready for me.
Awesome. All right. Before we begin, I want to let you know that we're broadcasting today's live, like as I mentioned on Facebook. So just a few housekeeping notes. Everyone who registered via Zoom will receive a copy of the presentation slide via follow-up email within the next few days. A server will be shared in the chat with a QR code at the end of the presentation, and we will have time at the end for Q&A. So we encourage questions at any time. However, please remember this is a public forum and we are being broadcast on Facebook. My name is Doris Rodriguez, and I am the Autism Initiative Coordinator here at the Metropolitan Parent Center. A few words about Synergia's Autism Initiative. The Autism Initiative project is funded by a grant from the New York City Council under its Autism Initiative. This project supplements the work of Synergia's Metropolitan Parent Center by bringing an increased awareness to New York City's residents, particularly to the communities with large Spanish-speaking populations, about growing numbers of children diagnosed with autism spectrum disorder. A strong outreach component targets families of children with suspected or known diagnosis of autism spectrum disorder who are not receiving appropriate educational, health, and other related services. This initiative will link them to other services and supports that meet the individual needs of children and their families. I want to thank you all for joining us. We are glad that you chose to be with us today. Before we get into it, I would like to introduce our presenter today. I want to welcome Ms. Catherine Sancimino, a clinical psychologist at Seaver Autism Center for Research and Treatment and assistant professor at the Department of Psychiatry, Icahn School of Medicine at Mount Sinai. So glad you could join us today.
Thank you. So I'm very happy to present, and I'm going to try to provide a very comprehensive presentation. And you gave me some questions ahead of time. Some of those I will be answering during the presentation, and some I can also answer at the end. So I will get started. This presentation is about the process for finding a diagnosis and intervention for autism spectrum disorder. And as you mentioned, my psychologist through the Seaver Autism Center, Dr. Catherine Sancimino is me. And the first section, I'm going to talk about what is autism spectrum disorder. And then I will talk about the diagnostic process, and then about interventions. So primarily autism spectrum disorder has two main components. There are impaired social and communication interactions. And then the second major feature of autism are the restricted and repetitive behaviors. So impairments in both of these domains must be present in order for a diagnosis to be made. The three required impairments within the impaired social communication domain are social reciprocity. So this can range from a lack of ability to have a back and forth interaction a lack of ability to have a conversation. It really depends on the person's age and level of ability when you're looking at what that impairment might look like. But for a very young child, it might look like not being interested in any back and forth play, not being able to roll a ball back and forth, not being able to have any sort of playful back and forth interactions. In an older child who has speech skills, it might be a lack of ability to have a back and forth conversation that's appropriate for their age. The next domain of impairment is impairments in nonverbal communication. So these are things like making eye contact, being able to show a wide range of facial expressions, using your hands and your body for communication. So nodding, shaking your head, but also doing things like using your hands to emphasize what you're saying, or using your hands to reference things that are farther away, to demonstrate something like, I'd like a cup of water, or I want one this big. Things like that. That's nonverbal communication. So individuals with autism show difficulties being able to use that. Also understanding other people's nonverbal communication. So having a difficulty understanding someone else's facial expression, or difficulty understanding someone else's body posture, or what it means when they turn away from you and look somewhere else instead of at your face. For an individual with autism, they might not understand there are social implications to not making eye contact or not facing your body toward the person you're talking to. And then the third area of impairment in social communication are impaired relationships. So having difficulty forming relationships with same age peers, having difficulty maintaining relationships. As a parent of a child with autism, you might find that you're the one setting up the play dates or reaching out to your child's classmates, trying to forge relationships. So those are impaired in autism spectrum disorder. The second main area of difficulty is the restrictive and repetitive behaviors. And I'd like to emphasize that these are problematic in the way that they impact someone's daily functioning. But on their own, they might not be problematic behaviors. So I'm just going to skip down to restricted interests, and that often can look like being very, very focused or fixated or maybe obsessed with one topic. That's not necessarily a problem to want to know so much about one thing. However, if it gets in the way of being able to learn about other things, or if it gets in the way of forming relationships because maybe someone only wants to talk to other people who have the same interest. So I just wanted to emphasize it's problematic in the way that interferes with daily functioning. So repetitive speech and behavior might look like instead of responding to a question, it might look like echoing or repeating what the other person says. So like maybe you say to your child, would you like water or milk? And instead of giving you an answer, they might say water or milk, instead of saying something that would be more helpful for communication. Might also be memorizing scripts from a movie or a TV show, or even what other people say, and then reciting it to themselves. Or saying it in the middle of a conversation and it kind of doesn't seem to make sense in the context of what they're saying. Insistence on sameness might be really wanting the same routine and being very upset, like more than you would expect upset about a routine being changed. So for example, if your typical routine is, get ready for school, go to school in the morning, and then you change that routine to add a dentist appointment, and then your child has a really significant tantrum on the way to the dentist because they're so upset that you changed the morning routine. And this also applies to adults too. Adults with autism might need to have their things set up in just the same way and get really upset if anything is changed, to the point of it being interfering with daily functioning. And then sensory abnormalities are things like being hypersensitive, like very, very sensitive to any type of sensory experience. Could be odors, it could be lights, it could be the way things feel on your skin, it could be sounds, or being undersensitive, like not noticing if they've fallen and, really severely have an injury, or seeking sensory experiences, like always wanting to touch and feel. So really, the abnormality means that it's just extreme in one direction or the other. So that's autism in a nutshell. And then all of these circles around these two main categories of symptoms are all the other things that can also happen with autism spectrum disorder. So there are often language impairments. So often individuals with autism might have a language delay. They might also have an intellectual disability, so lower cognitive ability. And this is not always the case, but it often does occur. There may also be genetic differences present. There are some genetic mutations that we know are associated with autism. There's also biomarkers, things that we can look and actually have, physical evidence that's of difference that's associated with autism. And then medical comorbidities, there are seizures are often associated with autism, but not always. Constipation is often associated, but not always. Sleep problems are often associated, but not always. So it's good to remember that these are things that can occur with autism, but they don't always occur with autism. There was a question about ADHD and autism, and would like to note on the behavioral comorbidities or co-occurring behaviors that hyperactivity and impulsivity is often occurs at the same time as autism, and ADHD might be diagnosed along with autism. So key facts about autism. The current CDC estimate is that there is a prevalence of 1 in 36 children diagnosed with autism in this country, and that boys are 4 times more likely than girls to receive a diagnosis. We can reliably diagnose autism by age 2. And what that means, reliably means, is that once we make the diagnosis, we're certain that it's correct, that it will not change. If the diagnosis is made much before 2, there's less certainty that it's a correct diagnosis. But typically, children are diagnosed after age 4, and that has to do often with access to a provider who can make a diagnosis. So here's some of the data around what I was saying about children who have co-occurring behaviors and symptoms, like an intellectual disability, that's a cognitive disability, and that's IQ of below 70. 30% of children with autism would have that co-occurring. And autism affects everyone in any ethnic or socioeconomic group. There's no difference between ethnic and socioeconomic groups. It occurs all over, and early diagnosis and intervention can have very positive long-term effects. Getting help early on can be very, very helpful. And the last point is there is no medical test to autism, which meaning that you can't get a blood test and make a confirmation of autism. It's currently all of our testing is all behavior observation, and it's a comprehensive evaluation. I'll talk more about that. And there's no cure, meaning that there's no medicine you can take that makes autism go away. However, treatment can be very, very helpful. And this current CDC Autism and Developmental Disabilities Monitoring Network has really focused on trying to understand autism across all different cultural and ethnic groups. And they have some really great data available that shows that there's actually a rising prevalence of autism across the different socioeconomic and cultural and ethnic groups. And I think what that means is that everyone is getting access to getting an evaluation and getting a diagnosis where it is appropriate. So what causes autism? What is causing the increase? That is a big question, and it's why there's so much research around autism. Autism is primarily a genetic disorder. So about 80% of the risk for autism is caused by gene changes, and changes in as many as 1,000 of our 20,000 genes can increase the risk for autism. So that means that there's no one gene and there's no one specific combination, which that's why it makes it a little bit more difficult to understand genetically. But there have been over 100 high-risk ASD genes that have been identified through research. Environmental factors are also associated with
También
Oh, sorry, should I speak a little slower?
something happened. We went out. I think the channel on program. Doris, are you there?
Back in the room, yes.
Yes, please. Thank you.
Go ahead, Catherine.
Okay. Can you hear me?
I can hear you perfectly.
Okay, and we're still going?
We're going.
Yes.
Okay, good.
But I have to wait until the channels is open. If not, then simultaneous is not gonna be possible.
No worries.
Okay.
Okay. Should I continue?
Yes, Catherine, go ahead.
Okay. So when I say environmental factors, that means the environment in utero. So when a woman is pregnant, there are environmental factors that can impact the genetic development. So advanced parental age, either the female or the male parent can impact and increase a risk for autism. Pregnancy and birth complications, so extreme prematurity. So that's before 26 weeks. So that's quite early. And a low birth weight can also be associated. I'd like to emphasize also that that doesn't mean a very low birth weight or before 26 is going to result in autism. It just means that there's a higher likelihood of an autism diagnosis eventually, if those are a factor. And then closer pregnancies. Really want to emphasize vaccines do not cause autism. I actually gave a recent presentation that addressed that as well. There are many studies showing that vaccines do not cause autism. I'll just kind of let you know that the original study that started that claim was retracted. The journal retracted that article. The individual who authored the study actually was found to have made fraudulent claims in the study. So the increase in prevalence is likely due to better screening and access to diagnostic testing. So people being able to get an evaluation and diagnosis has increased. The ability to understand autism and understand how to help children and adults who have autism has really improved over the years. And that is also resulting in more people seeking an evaluation. There have also been changes in diagnostic criteria. In 2013, there was a change in the DSM, which is the book, How We Make Diagnoses, Mental Health Diagnoses. And then also genetic environmental factors might also be contributing to the increase in prevalence of diagnosis. So it is important to note that most children, most caregivers of children who have autism did note that they have concerns about their child before age 3, but fewer than half of them did actually get an evaluation before age 3. And not for lack of trying. Often parents will try to get an evaluation for their child, but it doesn't work out for one reason or another. So more of these children are getting evaluations after age 3 and then even more after age 4. So the age of diagnosis tends to be that caregivers will express concerns about their child's development somewhere between ages 1 and 2. But then the average child from a non-minority background will receive a confirmed autism diagnosis around age 3. And typically a child from a minority background has been getting a diagnosis after age 4. Early intervention significantly improves outcomes for children with autism. That we know that to be very true. And the problem of getting a later diagnosis is you're missing out on that early intervention window. So the American Academy of Pediatrics recommends that screening, so just having mom or dad or caregiver fill out a questionnaire that asks questions about autism symptoms at age 18 months. So at that pediatrician checkup at 18 months, someone should be filling out the MCHAT. And then between 24 and 30 months, there could be a second screening for autism symptoms. If one of these questionnaires shows that there are some signals that autism might be present, then the family should be referred for a diagnostic evaluation. So that would be an evaluation with somebody like me, a psychologist, or a developmental pediatrician, or another professional who has expertise in understanding autism. And then once that diagnosis is made with a professional, then there's a referral to early intervention services. So these are the different types of assessments for autism spectrum disorder. That was, I think, one of the questions I was given in advance as well. So it's very important to note that the clinical interview, having a conversation about your child's development and your concerns about their development with a professional who has experience is a really important part of the process. The clinician should be trained on standard instruments, but also have education and experience to be able to identify what the parent is reporting, if that is an indication of autism, or if it's an indication of something else. The gold standard measures that we use really rely on the clinician being educated and experienced. So the measures themselves are very important, but they also need to be administered by a person who has the appropriate education and experience. So the ADOS, that's the Autism Diagnostic Observation Schedule, is administered by the clinician. It's called a semi-structured observational assessment. And what that means is that we do have a script that we're following, but we're also responding to the family and the child, and we're looking to see if there's interaction, if there's play behavior, if there's back and forth play. We also look to see if there's any repetitive behaviors that we notice in the speech or in physical movements. And then there's 5 modules of the ADOS. So the ADOS can be given to someone of any age, starting at the youngest I've administered it is 18 months. 12 months is pretty young. But they have to be able to move around the room and explore the materials on their own, explore the toys that we have out for them. But then module 4 is for adults and older adolescents who have fluent speech. So we choose the module based on age, based on language ability. And the administration time is between 40 to 60 minutes. It depends on the age of the person. And it really should go beyond that, because any longer, the time becomes, the individual being assessed becomes fatigued. And then you might just see someone who's tired. And when we're tired, we show not our best social behaviors. The ADI is the Autism Diagnostic Interview. This is a very comprehensive, very thorough interview about symptoms of autism that are present from early age, And we focus a lot of that interview on the years between ages 4 and 5. Granted, you can still give the ADI to a child who's younger than 4. It'll just be a bit of a shorter interview. And then this also can be given to the caregivers of people who have reached adulthood. The important part is that the person being interviewed needs to have known the individual being assessed for their early childhood. And it's a very long interview. So there's many other steps in the comprehensive diagnostic process. So those are the two kind of gold standard instruments for autism assessment, but we provide additional assessments that are very standard, and there should always be a cognitive evaluation that's looking at their intellectual functioning. There should always be an adaptive measure. Many parents might be familiar with this one called the Vineland or the ABAS. Those are just two different tools that could be used for the same purpose. And that's to get a sense of how much is your child or your adult child doing the things that are expected for them based on their age on a daily basis. How much help do they need to do the tasks of daily living? And then there may also be a speech evaluation if that's appropriate and needed. OT is occupational therapy, PT is physical therapy. Those evaluations often occur as part of an evaluation for school services, but they can also be provided through a medical evaluation. It is important to rule out any sort of medical problems. So for example, any hearing or vision problems, that absolutely would affect social interaction. And then the SAND, that's a sensory assessment for neurodevelopmental disorders. And that is helpful to identify reactivity to sounds, to different sights, how much someone is over or under-sensitive. And then the clinical interview itself, that's the caregiver's conversation with a professional psychologist or other provider. Family history is important. Psychiatric history, have there ever been any other psychiatric problems? Developmental and medical history, as well as the current symptoms that are most concerning. So as far as what interventions does the patient need and at which frequency, that is very dependent on their level of need. So we look at their cognitive and language abilities, adaptive skills. Adaptive skills are those that we look at kind of daily tasks, how much you're doing the tasks of daily living. If there's any co-occurring disorders, those are comorbidities, and what age. So that this is not going to be the same for each individual. It will vary based on their age and their level of needs. These are the different types of interventions and supports that are available. Behavioral interventions, meaning that these are through play and through social interaction. It's ABA, Applied Behavior Analysis, has many different forms and may be appropriate for many different ages. And what it's really looking at is what are the behaviors that are problematic, and let's find new behaviors to teach or change or replace the behaviors that are problematic. There are naturalistic ABA approaches. So Early Start Denver model is really great with young children, and as is pivotal response treatment. They're about using an ABA model, but in more play-based interactions that are really engaging for the child. Teach is another very, very well supported by evidence intervention. And then social skills training is focused on peer interaction. So that's often with a group of children, and teaching kids about how their social communication is being received by other people and how to improve their social communication, really for the goal of having more positive interactions on a daily basis. Cognitive behavioral therapy is very appropriate for children who are older or adults who have the ability to engage in a conversation about their own behavior and identify what their thoughts are, what their behaviors are, and what their feelings are, and how those three things can interact to impact the way they feel and how successful they are in having, a positive day. So CBT can be enormously beneficial for the right age and cognitive ability. There are many educational interventions, and in New York, these are provided through early intervention and CPSE, and then as well as the IEP. So whichever one of those your child is eligible depends on their age. So early intervention starts from 0, starts from birth, and goes up until age 3. And you'll identify, I'll go into it again in another slide, but eligibility is determined, and then services are provided in that 0 to 3 window of age. And then CPSE is the next step in New York. It's the Committee for Preschool Special Education. Basically, when your child is too old for early intervention, but is still not yet in public school, then you can get an evaluation to see if they could get some preschool services. So from ages 3 to 5. Often early intervention services are provided in your home, and then CPSE services are provided in a school. It's not always the way it is, but it's frequently that is the format. And then Committee for Special Education is school-age children, so ages 5 and older, kindergarten all the way up through the end of high school. And the stopping point really depends on their birth date and how close they are to age 22. A 504 plan is another type of intervention that is not the same as special education, but it is related to getting accommodations in the school setting that are appropriate for an individual with a disability, and that also can translate to a workplace or to like a college environment. Whereas the IEP does not travel to college, it doesn't travel to a workplace. It's only for K through 12 public education. There's many related services, and these services can happen through the school, through the IEP. They could also happen through a medical setting, or through a private practice, or through an organization, a nonprofit. So there's many different ways to acquire these services for an individual who's eligible and appropriate for them. Physical therapy, speech therapy, occupational social skills, parent training, all of these might be appropriate. Parent training can be especially helpful to help parents understand what their child's therapy is aiming to do, and also how they might supplement at home, how they might look at their interactions with their child and try to understand them through the lens of the therapist. So parent training can be enormously helpful. I realize I think I'm going to work a little bit faster through my next few slides. Early intervention is federally mandated, and it's coordinate services. So often for early intervention, children don't need to have a confirmed autism diagnosis. They might just show enough delays in perhaps in their speech, in their social development, or in their physical development that they're eligible to get services, even though a formal diagnosis of autism has not been made. These are free evaluations. The family does not pay for these evaluations if you get them through the early intervention program. And the services might include ABA, that's applied behavior analysis, the speech, OT, feeding therapies are also common within early intervention programs. Specialized instruction, that's you might have like an aide, like a one-on-one teacher for a few hours a week. So there's a lot of different types of services that are through EI. And so again, I'm talking about New York. Early intervention does not cost the family anything in New York. Other states might be different. And this is very important. You can self-refer for an early intervention evaluation. So let's say you are concerned about your 18-month-old or your 2-year-old, and your pediatrician appointment isn't until 6 months from now, but you're concerned right now. You can actually refer your child on your own. You don't have to have your doctor do it for you. I mean, I'll talk about how to do that. So just more information about the CPSE services. That's for preschool age children, 3 to 5. Again, in New York, it's provided free of charge through the public school system. You have to get an evaluation first, identify if the services are needed, and then the services would start. And they often would be in the school setting, like in a classroom setting. And then there's also additional aids and services that could include any one of these things. It could include a paraprofessional, assistive technology. So that would be like a device, a communication device, or even a board, like we call it PECS, picture exchange communication system, where a child who has delayed language might use a picture card to give to their teacher or to give to their caregiver to make a request. And then a device like an iPad or something would have a similar program. So there's a lot of different types of services through CPSE. And again, if the evaluation is done through the school still might not confirm an autism diagnosis. They could get services that are appropriate even without confirming a diagnosis, if it's through school. So just some information about what is IDEA. It's an act that was passed in 1975, and it was really brought to the attention of the federal government really through a coalition of parents who wanted to make sure that their children were given appropriate education as citizens of this country. And much has developed since then. And it covers all school-age children who fall into one of 14 different categories of eligibility. And these are some of the categories that your child can be eligible for any one of these categories. Sometimes they have more than one, but typically the school system chooses a category. And that is once they're in the school-age programs, CSE. So there is a note that if a child is given an IEP, it's because there's evidence that their disability is negatively impacting their educational performance. It can be the case where your child has a diagnosis, but they're doing just fine at school. They're getting, their grades are passing. They're not having any behavior problems. They're getting along okay with their peers, and they don't need an IEP. Like, that is very much possible. So in order for a child to get these special services, there has to be a demonstration that their disability is actually really negatively impacting their educational performance. So understanding the classroom setting options. There's different settings, and this really also depends on where your school is and what the school offers. It might be that the best program for your child is not in your local school. So mainstream classroom, general education is typical public school. There's also ICT classrooms when there's one general education teacher and one special education teacher who work together to teach the classroom. And in the classroom, it could be a mixture of students who have an IEP because of their disability and students who do not have an IEP or general education students. And then there's also self-contained classrooms. So these are very small classrooms in which all of the students have an IEP, and they're all taught by special education teachers. These additional interventions that I mentioned previously are the additional services that are available within the school system. There's PECS, that's what I mentioned, the Picture Exchange Communication System. These are different interventions that the speech and language therapists will set up and use. Based on the child, they'll choose what's most appropriate for the child. Occupational therapy, the goal is to be independent in their daily tasks and their daily functioning. So occupational therapists will focus on the things that a child needs to do to take care of themselves at an age-appropriate level on a daily basis. So it might be things like zipping their zippers, buttoning their buttons, but it might also be things like when they're feeling overwhelmed because they're hypersensitive to light or they're hypersensitive to sound, what can they do to help themselves feel calm when they're exposed to lots of noise and light? Additionally, if they're very sensory seeking, that is, always wanting to touch and feel things, they might recommend something, maybe a weighted vest or a weighted blanket to help them feel focused when they're having that desire for lots of sensory input. That's what occupational therapists might do in the school setting. And then physical therapy would address deficits in motor development. So things like running or moving or climbing, and as well as fine motor development. There might have to do with like pencil grip or writing. This would really depend on what the child's needs are. Okay, so I'm going to speed it up a little bit and just an introduction to our center and clinical trials that we're recruiting for currently, and also in general, just to improving the experience for patients who are neurodiverse, who are coming to Mount Sinai for their services. So our mission at Seaver is to enhance the diagnosis of autism and related disorders, really discover and understand the biological causes of those disorders. Hence, our research is genetic in nature, and to develop and disseminate breakthrough treatments to help people who do have genetic disorders that we can understand. So we strive to bridge the gap between new discoveries in basic science and enhanced care, while ensuring the community is aware of new and improved approaches to caring for people on the autism spectrum. So we do a lot of research, and I am part of the clinical team, so I'm not the best person to explain what we do at the molecular level. We have so many different team members. Today's presentation is less about the genetics and more about understanding the behavioral aspect of autism and understanding the process that you'll go through as a caregiver in order to get services for your child. We have got a lot of wonderful experts here, and you're always welcome to contact us if you'd like to learn more. So the assessment and genetics course sees approximately 180 individuals each year through the Seaver Autism Center. And our team includes psychiatry, psychology, neurology, and clinical genetics. And when an individual participates in research for one of our studies, there is a free autism evaluation. And that's because when we need to confirm that the individuals that when we're doing genetic testing, we have to ensure that they meet the clinical criteria for an autism diagnosis. So if your child or you are participating in research at our center, you would meet with me or someone like me, another psychologist, to do diagnostic testing to identify if you do show symptoms of autism spectrum disorder. And that would be that psychiatric evaluation, interview about developmental history, current symptoms, medical history, etc. And then it would also include the ADOS, which is that play-based observation, interaction-based observation that's semi-structured. I talked about in the very beginning. One of the 5 modules would be administered, and the toddler module, and then modules 1 through 4. And then the ADI, the Autism Diagnostic Interview, is another tool that may be used for evaluation. And then after that, the genetic testing would be done. When we say additional phenotyping, we are referring to cognitive, intellectual development testing to identify cognitive abilities, adaptive behavior to understand. That is an interview with the caregiver to understand how much activities of daily living are being performed by the person being assessed. Getting a sense of sensory behaviors, whether someone is over or under sensitive to their environment. And then also language abilities and neuropsychological tests may be done as well. It depends on the study that they're participating in. And then we also provide other services here outside of research as well that are ongoing and changing over time. So one of our studies I'll present to you right now is the genetics of autism in Latinx ancestry. So it's GALA for short is what we call that one. The purpose of this project is to collect genetic and clinical information to understand genetic risk for autism spectrum disorder. We have Spanish-speaking coordinators. We also have a Spanish-speaking provider who would provide the evaluation in Spanish and interpreters. So if your family speaks only Spanish and your child has autism, or you think your child does have autism, but you have not had a diagnosis, but there's a lot of evidence that they do have autism, they would be a good participant, a good candidate for this study. To be a part of the study, you would have a clinical evaluation with me or another psychologist, again, depending on language level. There's a blood draw and a saliva collection that's also required for the study. And really the purpose is that Hispanic Latinx families are the largest minority in the United States, but little attempts have been made to include this population in genetic research. There's a dearth. We don't have enough representation in genetics research. So that's why this study is going on. So English and Spanish speaking families alike are eligible to enroll, and you're very encouraged to contact us if you're interested. Another clinical trial that we have going on right now is enrolling 2-year-olds to 12-year-olds who do meet criteria for autism spectrum disorder. And participation lasts for 7 months. There's 5 in-person visits and 6 remote visits, and there's questionnaires that are completed at every visit. And every child who participates will receive the growth hormone during one of the phases and placebo during the other. So if you're interested in the human growth hormone study, please feel free to contact our clinical coordinator for that one, Katie Friedman. Her information is there. This presentation also will be shared with you at the end. So this information will all be available. And then we have another new project examining caregiver satisfaction with the sensory interventions for children. So children who are, as I mentioned, hypersensitive to sounds or light or textures, or undersensitive to a point that it causes a problem in daily functioning. And so there's anonymous surveys to identify the sensory interventions that they perceive as the most effective. And they'll be coded to determine the most reported and highest rated interventions within those sensory modalities. So if you have a child with autism who is very sensory, oversensitive or undersensitive, I do encourage you to participate in this one as well. It really helps the community at large when you participate in research. And then, Mount Sinai also has a lot of free resources available. So Peak is basically our kind of education platform filled with a lot of videos that provide information about clinical recommendations, educational trainings. Many of these Seaver has created and made available to the public. So I highly recommend logging on and watching some of those videos. The video will let you know in advance also how long it is so that you can adjust your time. We also have sensory toolkits available here. So the sensory toolkits are like a bag of items that can be helpful, kind of like a fidget, to a child or adult who might need a little bit of extra sensory input. So we made these here at Seaver, and there are kind of instructions on how to use some of these on-the-go interventions. If you are interested in having one of those, you should contact us. But we also would really like to know some feedback on how people are using these, if they're useful, if they find them to be something that's been helpful. So if you do acquire one of these, please let us know through the feedback form what you think of it. More video resource library and social stories. The social stories can be really beneficial when your child who is a little bit older or cognitively able is going through a new experience. A social story, basically, it's a series of pictures and words to describe the pictures of what a new activity might be like. So for example, if you're taking your child to the dentist for the first time, you might create a social story that has a picture of the bus or the subway or the car you're going to take to get to the dentist. It might have a picture of the front door of the dentist. Then it might have a picture of the reception area. Then there'll be a picture of the dentist chair, and then the dentist, and then maybe a picture of a child having their teeth cleaned. Then there might be a picture of, kind of a smile at the end of it, and maybe the little small prize that they get at the end, maybe a picture of the little bag that they take home from the dentist. I use dentist because it can be a pretty, scary experience for an individual who's hypersensitive to lights or to touch or to texture or to sounds, because there's a lot of stimulation at the dentist's office. And by having all these pictures, you would sit with your child and go through, this is what we're going to do next, that's what you're going to do, and you prepare them for what to expect at the dentist, to reduce the fears they might have around that upcoming experience, and also for you to recognize what they're going to be most reactive to, so you can be prepared, maybe to bring their favorite stuffy, to bring a blanket, to talk to the dentist ahead of time, to let them know that they might need to take a break at some point. So social stories are really about providing an opportunity for an individual to understand what they're about to get into, and to find ways to feel relaxed and calm when they're actually feeling quite nervous, and to address that anxiety. So I have reached the end of the presentation section. And this is when we're going to be stopping the recorded part, because now we're going to move into a question and answer period. I'm happy to answer questions. We just didn't want them to be recorded because sometimes people might ask a personal question that we don't need to be recorded. So, so thank you all for attending, and I'm available for question and answer now.
Awesome. Thank you, Catherine. So as mentioned earlier, we will now be opening the floor for Q&A with our presenter. Please make sure to write all your questions in the Q&A or on the chat. For those joining us via Facebook, to secure a copy of our materials from today's webinar, please contact our intake line. This presentation will also be posted on YouTube. And as Catherine shared, we will now be ending the live and recording.